Well, good evening, everyone. Welcome to this section of Innovation Theater. I'm Connie Steed, and I'm an infection preventionist. I've been an infection preventionist for over 40 years, actually 46 almost. And greater than 50% of those years were as a leader in infection prevention control. I took baby steps, became a manager, then a director, and then before you knew it, I was the director of a corporate healthcare organization that was very complicated and complex, multi-hospital, and my responsibility was managing the program over the continuum of care in the communities they serve. Now, do you think that was fun? It took a lot, and it didn't just take me. Does everybody know in this room? I know you do, because you're patient safety experts and leaders, that it takes more than one. It takes a team. So why am I here talking today? I'm here because what I learned during my journey as an infection preventionist is that I had to show the organization the total value of a good program. Now, what I mean by total value, we give them data. We show them how well we're doing when we do well, and then when we're doing bad, we show that. But many times we don't go back and show them what happened after we did something about the bad. And so one of the things that I learned is that I needed to give the side of the picture that many leaders do not understand, and that's the impact on operations and finances in the healthcare organization. So today, I'm going to very briefly, in 30 minutes, give you a quick overview about translating infection reduction to operational and financial metrics, with a focus on the impact on length of stay, which is a key metric for leaders, and what happens to revenue with that. So I'm going to explain real quickly why and how to translate patient safety improvements into metrics that are important to executive management. How many of you heard the rule? If you want to get their attention, you got to get it, and you got to do it in one page or an elevator speech, right? And then describe how leveraging an effective infection control programs can deliver not only quality, but operational and financial improvements required in today's healthcare environment. Because I think we all know in reality that our mission in healthcare is to take the best care of our patients all the time. First, do no harm. But does that happen? No, it doesn't happen all the time. And that's why we're here today. And lastly, I just want to make a brief comment that quality leaders can assist infection prevention teams when they don't give you enough information. Share with them how they can define and communicate the value that they give the organization when they reduce HIIs, because it's impactful. And you can actually do this for any hospital-acquired condition. I'm just using HIIs because what have I been doing for 40 years? Mitigating risk and preventing infection, saving lives, and reducing morbidity. That's what I've been facilitating. So, is patient safety a balancing act with cost? I'm asking that question. It says no because it shouldn't be, right? It shouldn't be. Is it? Yes, ma'am. There are. But what I've learned, so the reason why I say that is that's just one way we got to show value. We heard it implied several times today about the expenses and the financial dilemma that we're in healthcare. So we got to make sure that when we want something and we think it's going to be great for the program, that we can justify it. And then after we do it and it works or doesn't work, we go back and show them the data. So that's what I'm going to talk about today. Actually, what I have found in all my hundreds of years of working in healthcare is that when you improve quality to the point that you're efficient and you sustain the processes, you got to do those two things, you will reduce cost. How do you do it? By HIIs? You reduce the HIIs and you reduce a key metric, length of stay. That's where the money is. And it also relates back to throughput. Is that a favorite word of leadership? Honey, it is. And why is that? Because many of our organizations have packed ERs, and they can't get upstairs because why? Our beds are full. So a key metric for leaders, if it isn't, it should be, is length of stay. And what happens when you improve care and you reduce complications? You reduce length of stay. You also reduce readmissions. You also reduce penalties. And I think I don't need to really say much more about that. You understand. So this is me on a given day back a long time ago when I worked in this complicated system. And you see, do you all have a lot of little bubbles around your head and you've got so much going on, right? One of the things I learned that's really important is that we focus on quality programs that have meaningful impact. You know, we have time, energy, and yes, we need to have passion to focus. And we heard one of our speakers today talking about the fact that we can't do everything. So we need to establish priorities and make decisions. And so I think we need to have guidance, and I think all of you know what that guidance is. Whatever you do, it has meaningful impact potential if it's aligned with organization priorities. You got to make sure it's something that your leaders have made a priority for whatever reason. Your data shows in your risk assessment indicates that you've got a huge problem with central line associated bloodstream infections or C. difficile or whatever it is. And they want it down because it'll help improve quality, but it will also do what else? Reduce potential penalties, which really have a tremendous impact in many hospitals. So that helps you with knowing what the quality care issues are in your organization and what the leaders are concerned about. And they're not concerned about something that you think is important. You need to communicate to them. They will eventually listen if you have a short elevator speech and it gets their attention. You also have to look at fiscal and operational improvements. And this is one of the key things I learned as a little IP. We got to talk money. We just have to. If you're on quality, we're cost centers, by the way. Quality, patient safety, infection control, cost centers. Do we make revenue? We do not. So when they have to reduce resources to help balance the budget, where do they go? Take one of your leaders. Well, whatever. They do something, don't they? I bet everyone in this room has dealt with that. So that's why we got to talk finance. We got to make sure that they understand that when we do our jobs well, we are worth every buck, and we do have impact on the bottom line. And I think that's very important. I've already mentioned regulatory penalties. What about accreditation readiness? Is that a fun thing to do? So if it has something to do with making that better, that's, I'm telling you, an organizational priority. And then we always want to have a good reputation in our communities, but also via our PLers and other healthcare organizations. So make sure that whatever you do and your priorities are have meaningful impact, and I think that's vital. One of the things that I've learned over the years is that leaders, healthcare leaders, really do not understand completely the economic impact on hospital-acquired conditions. This is a publication from a meta-analysis that IHI did that was published in 2017. This is the economic burden on these top hospital-acquired conditions per case. The ones bolded in blue are HAIs. What are the top three? HAIs. They cost more than all these others per event. The other thing I want you to see is the studies that were involved in the meta-analyses. You'll see that the studies are more robust with HAIs than they are with others. So that if you use this data as an estimate to project what you can do to mitigate risk and also affect the bottom line, this is an excellent resource that's very well respected. Who doesn't respect the HRQ? So how am I going to share this information with you very quickly in the next 15 minutes? I'm going to give you a hospital example. to show you the impact of effective infection risk reduction. This hospital will go nameless at their request, but they've given me full approval to share their experience, and they've actually published and done some abstracts that's been presented at APIC and also at ID Week, one of them at ID Week. And they wanted me to share all of their information. So that's what I'm going to do today as it relates to HIIs. This is a 300-bed community hospital in Midwest part of the country. They had concerns, like many of us, about increasing HIIs, had tremendous increase in their penalties. And so their quality team and leadership said, we got to do something. And their biggest priority was CLABSI. And so what did they do? They implemented a PI team and went all through all this stuff that we know how to do. Key to it was doing a root cause analysis to find out why there was an increase. And they also searched the literature to see if there was anything else new that may mitigate risk further. And that's where they found nasal decolonization. And they also had a new IP that had worked at a hospital that implemented nasal decolonization that went 370 some odd days without a CLABSI. So they decided that they would propose it. It got approved by the organization, and that's a history unto itself. I can tell you that story, but we don't have time. And they decided to implement it, got approved for implementation. And eventually, when they did it, the patients that it impacted was about 65% of their patient population. So it had a huge impact. And what I'm going to share with you is their 2-year pre- and post-implementation data. So this is their CLABSI rate over a 4-year period. The red line is their ICU. The teal line is their non-ICUs. The red line, their ICU data has been presented in an abstract at APIC. The general ward data was not. But I think it's important to show what happened outside the ICU because they implemented nasal decolonization in all patients that had a central line. They also implemented it in other high-risk patients that they designated like home health, nursing home patients, et cetera. And that's why it affected so many people. What happened after they implemented this alcohol nasal antiseptic? What happened to their ICUs? 0 CLABSIs, guys, for 2 years. 0. Did they sustain it? Yes. And I just talked to them 2 weeks ago. Since this time in 2024, all of last year, they did have 2 additional CLABSIs in the ICU, and that is it for another year. So, do you think this is impressive? I think so. Look at their p-values. So what they did was take that information and they put a little bit of estimation to it using some data from the research and from their facilities. 2-year pre-implementation, they had 19 CLABSIs at that $48,000 whatever dollar rate of infection. So the cost of those 19 HIIs was close to $1 million, and comparing to the last 2 years where they had 1 CLABSI, 19 to 1. And look at their total estimated treatment cost reduction. Now, many of you in the room that are leaders know that's really a drop in the bucket when you look at budgets, but it's still important. I will also tell you, because I have, one of the keys is to get a financial co-conspirator, somebody from the finance department to help you. Am I right? They can help you make sure that what you present is going to be acceptable to your leadership. So what I found is they say treatment cost, oh, there's soft cost. It doesn't affect the bottom line. Anybody ever hear that? So that's when Connie added, and this hospital added, looking at length of stay. And what you see here is they used an excess length of stay per infection of 7.5 days from the literature. Okay? Now, I did a real drill down analysis in my hospitals of CLABSIs, and the average length of stay increase for our CLABSIs was 10 days if they were critically ill, and it was 7. And so this sort of matches that. But they didn't do their own study about their data because you know how long it takes to do that? A long time. They don't have that data. So use data to estimate potential benefits. It still gives you the idea of the value that you can give them. So what they did is they used some of their information from their organization, their number of excess days, their average daily census during the 2-year pre and post implementation period. And they also took their average cost of one patient treatment day in the hospital, how much that costed. In this hospital, it was $6,520 per day. Now, they averaged them all together because you know ICUs cost much more than a regular bed, right? And then they did some math, and what they were able to do is show that when they reduce that length of stay, they have a potential gain revenue via excess length of stay avoided of almost $900,000. Okay? You see how that works? Simple equation, and it still showed them an estimate. It takes 5 years to do the data to that level. That's been done, and we have some information we can use. But this is what the Director of Infection Prevention is going to be showing their leadership very soon, because what he's decided to do is expand nasal decolonization to all of their patients that are greater than 2 years old. Now, that's just CLABSI. They also looked at MRSA Lab ID. Now you can see they had some bumps there along the way, but they still had a 49% decrease in MRSA Lab ID from the first 2 years to the 2 years post-implementation. And as of a week ago when I talked to them, where they had that reduction to 0 for like several quarters in a row and then they had a 0.4, they have sustained that. They had an opportunity there in one of their units, which happened to be a dialysis unit that they had to take care of. Over here is NHSN Surgical Site All Procedures Adult Complex. This is the metric that CDC has. This hospital decided they were going to monitor its impact on surgical site infections by using this general metric. And what you see there is that quarterly SIR over time. They didn't implement it in surgery until about 5 months later. They implemented the CLABSI stuff first and then went to surgery. And what they saw was a 38% reduction in all-cause surgical site infections, and it was statistically significant. The key is they'll tell you very readily that they still have opportunities for improvement as it relates to surgical site infections. Everybody's getting that little alcohol thing in the nose preoperatively. Take 60 seconds, it's done. But the protocol calls for administering this decolonization the duration of their hospitalization. And so they're having some compliance issues in that area. Now, the other thing they did during this period of time for the OR is they implemented a focus on colo resections. I wonder why. And they implemented a colo bundle, including the nasal decolonization. And it was so successful that they actually presented that at the APIC conference this past year. Very well done information. So has this organization been successful with using this new strategy? So if you look at all of them together, you can see the percent reductions, the amount of total avoidable treatment cost, and then the revenue that's potentially gained by those length of stays avoided. Now, I didn't show you all the detail about the other HIIs about length of stay and stuff because I don't have enough time. But this is what he is fixing to show his leadership with the request that he expand it to help deal with those dialysis patients that go all over the hospital and aren't in one place and stuff like that. I think he'll get approval. So why does nasal decolonization work? Real quickly, I'm going to tell you why, real quick. One of the predominant organisms that causes HIIs is Staph aureus. Did y'all know that? Did you know that 30% of our patients that are admitted to our hospital have nasal colonization with Staph aureus?
When they come in?
When they come in on admission. And then 5% of that 30% have methicillin-resistant Staph aureus colonization. Now, it's not causing a problem there in that nice nose. It lives there. We have normal flora in other parts of the body, right? But what happens is we self-inoculate. Staph aureus is the predominant pathogen causing CLABSI outside the ICU, surgical site infections that set GI, ventilator-associated pneumonia, and peripheral vascular catheter bloodstream infections, which are, it's crazy. So it's a predominant organism. All you have to do is go check NHSN data and you'll see it. So when you look at breaking the chain, they did research. Some folks said, where's the Staph aureus come from? Well, people knew that there was staph in the nose, and they thought, is there a connection between the nose and their site of infection? So there were some research studies done, some on surgical site infections, one on CLABSI, and then one on ventilator-associated pneumonias. And in the CLABSIs and the SSIs, greater than 80% of the patients with a Staph aureus infection at either site were molecularly the same. So they concluded what? That the organism that caused that patient's infection resided in their nose. It's still a hospital-associated infection, guys, by the way. Ventilator-associated pneumonia, about 94% of them had the identical strain. So the conclusion is, very true, you can go Google it, is that the nose, the nasal vestibule, is the major reservoir for Staph aureus in your normal microbiome. So let's look at the chain of infection, basic stuff, but we're going to focus on the reservoir of the nose because that's what we're talking about. What if you decolonized the nose and got rid of some of that Staph aureus? What do you think would happen to the potential risk of transmission? You'd think common sense says it'll go down, so keep that in mind. Well, when you have transmission, you have to have a portal of exit. What's the method of transmission? The nose. And you think, well, the nose is up here, not down here. How many times do we bring our hands to our face every day? The study shows over 100 times. Our hands go here. We get whatever nice bugs there. I hope you don't pick your nose, but that would make it worse. And then our hands go wherever they go, where it goes, the bugs that are there. And so what happens is they self-inoculate. Portal of exit is from the nose to the hand to wherever they go. Another thing about this transmission is exogenous sources of transmission. If they don't have it in their nose, where is it at? Healthcare workers' hands, contaminated equipment, their patient environment. Did you know studies show that after a patient's in their patient room for 24 hours, their room develops and expands their flora. It's not just the patient with the flora, their room is colonized. People don't know that, but that's the reason why IPs fuss about, well, you just can't worry about touching the patient. It's touching things in their room, in their equipment. So how do we break this chain? Basic infection control, hand hygiene, disinfection of equipment, disinfection of the environment. What's your compliance rates on those things? So how about make the environment better and mitigate colonization, reduce colonization pressure by decolonizing noses? That's how it works. That's how it works. So the other thing we do, we love to care for our patients if we don't kill them. And one of the things we do to make them better is what? We have to insert things in them. Lines, NG tubes. They let sit in the bed too long, they get a pressure over, which is one of those hospital-acquired complications. Is that a portal of entry? Yes. So when patients are admitted to a hospital and there for any period of time, is their risk of infection higher? Absolutely. So get in and get out is the best thing for the patient. So is there any evidence that this works in the literature? There are evolving studies, and I can't go over all of them, but one of the reasons why this hospital chose alcohol antiseptics is because it's short-acting. It takes 60 seconds to effectively decontaminate or decolonize the organisms in that nose. And they tested other pathogens. Did you know that if your patients are admitted to the hospital, if you're endemic with an organism, let's say you're having an outbreak with Klebsiella pneumoniae, CRE or whatever, they can acquire it because of their environment that they're in. Make sense? And so alcohol is effective against those other bugs. The studies here, real quickly, I can't go over them. They have over 20. Some of them are small studies. A few of them are larger. This one is a favorite of mine because of the way this organization did it. It was published in 2019. But they had a real bad problem with MRSA Lab ID. Their SIRS were off the charts. And so this hospital's protocol was to target, screen, and isolate for MRSA. Clearly wasn't working. So they decided, after looking at the literature, they would add mupirocin to all ICU patients, and they also implemented CHG bathing. They had some improvements, but it wasn't enough, and they were concerned. So they said, let's do something really off the wall. Let's test something else and see if it works better. So they eliminated mupirocin in all the ICU patients and added universal nasal decolonization with the alcohol-based product for the whole patient population. They expanded it outside of the ICU. They did all patients. And they continued CHG bathing and expanded it outside of the ICU as well. And the only thing they did in the fourth phase was add hand sanitizing wipes at the bedside for the patient. Okay? What did they see? A 74% reduction in MRSA bacteremia in this hospital. There are other studies that also share similar results. Some are better, and they did universal application of nasal decolonization. Some people ask me about pediatrics. There's not much on it, but this abstract was presented 2 years ago at APIC, and it was done in a children's hospital where they developed a decolonization program for their pediatric ICUs that was effective. Surgical site infection reduction, there's a lot on this, and I'm just focusing on the studies where they already had a nasal decolonizing agent, the top 3 mupirocin, the bottom 2 povidone, and they transferred to another nasal antiseptic, and they saw significant reductions in SSIs, all-cause organisms, just not Staph aureus, all the pathogens. Really impactful. Now, this last study I'm going to show you before I finish is one that I'm proud of because I'm a co-author on it, and it's a meta-analysis that was done on the efficacy of alcohol-based nasal antiseptic versus mupirocin and iodophor. The bottom line, because it's time for me to finish, is that there were 3 hypotheses. One, alcohol by itself, one when they transitioned from mupirocin to alcohol, and one when they transitioned from povidone and iodine to alcohol. Statistically significant values in all of these meta-analyses with significant reductions. So the conclusion from this study was that alcohol nasal antisepsis is a viable option for nasal decolonization. So in summary, what I talked about today is it's important for us to show our whole value. We have to align with organizational priorities. We need to leverage the full value of your program, whichever one you're talking about. It could be falls, it could be whatever, in this case it's HIIs. We got to present metrics that leadership cares about. Find out what those are. I will tell you, throughput and length of stay is one of them. And then we need to work with our IPs, if they aren't already doing it, to help facilitate that they show the value of their organizations, that they show that their program is effective, so that they get the visibility and the support they need to continue their journey to zero harm, which is what we're all about. So I appreciate the time. I suspect I won't have time for questions, but I'll be around a little bit after this if you have anything you want to ask me. And if you have questions, here is my email. And if you want that meta-analysis, I can send it to you at the email. If you have any questions about the product, there's a card on the back table that gives you information of a person that can help you with the product. I don't do product, I just do quality. All right, thank you very much. I appreciate your attention.